Here begins part 3 of the lecture on the imaging of benign solid neck masses. There are a variety of vascular pseudotumors that can simulate masses in the neck either clinically or radiologically. Tortuous or aberrant arteries may present clinically as masses. Varices usually aren't evident clinically because they're collapsible, but they can fool the unwary radiologist. Pseudoaneurysms often present as pulsatile masses, and vascular malformations, remember that low-flow venous malformations is the proper term, but everyone still calls them hemangiomas, also present as masses. This could be a confusing appearance both clinically and radiologically. This is a palpable mass in the lateral aspect of the neck in the posterior triangle. It's not where the vessels belong. But if you do a reconstruction, you get to see that this is really just a tortuous common carotid artery heading out laterally and creating a bulge in the posterior triangle. It's a conundrum clinically, but an easy diagnosis when you do your reconstruction of your CTA. Usually, the subclavian artery has the good sense to stay down in the thoracic outlet and not come up into the visceral space of the neck and displace the viscera. But every once in a while, you get an aberrant subclavian artery, usually as a result of atherosclerotic disease in older individuals, and it can appear up in the neck where it has a pulsatile mass clinically, and it can have a confusing appearance radiologically, particularly on unenhanced scans. Once you see that it has arterial enhancement and you can follow it along, it's much less confusing. So here's a confusing retropharyngeal mass. Are these lymph nodes behind the larynx here? There's this pair of them right next to each other. Well, if you do a contrast-enhanced scan, it becomes a little more obvious what's going on. These are the internal carotid arteries in a retropharyngeal course. So retropharyngeal internal carotid arteries. When they both are retropharyngeal and they almost touch one another, we call those kissing carotids. This is a potentially confusing radiologic appearance. What is this mass sitting out in the lateral neck changing the contour of the posterior triangle of the neck in the supraclavicular region? Very concerning for a lymph node in level 5. But what this actually is a varix of the internal jugular vein right about where it meets the subclavian vein to form the brachiocephalic vein. These varices are much more common on the right than on the left, presumably because of back pressure from the heart. It's somewhat easier to appreciate the vascular nature of this lesion on a coronal reformatted image where you can see it coming directly off of the vascular structures as they come together. Even here a little bit confusing, but the fact that it is enhancing along with the other venous structures in the vicinity is a helpful clue. Here's another varix, this time in the parotid gland. It would be very easy to mistake this for a parotid neoplasm, maybe a pleomorphic adenoma. But where's the retromandibular vein? The retromandibular vein should be running right through here, right? And it's absent on this side, or rather this is the retromandibular vein enlarged as a varix within the parotid gland. So the absence of the normal structure there is what clues you into the correct diagnosis. Pseudoaneurysms generally arise from the internal carotid artery just below the skull base. How can I be sure that this huge mass here is actually a pseudoaneurysm? Well, first I've got to figure out what compartment in the suprahyoid neck it came from. And so I noticed that the parapharyngeal fat has been displaced anteriorly and medially. That tells me that this came from the poststyloid parapharyngeal space and is either a vascular or a neural tumor. Is it a paraganglioma? Well, it's certainly enhancing the right amount, but where is the internal carotid artery? Here it is on the unaffected side. Where is it on this side? That is the internal carotid artery. It's absurdly expanded as a pseudoaneurysm from previous trauma. So knowing that this arose from the poststyloid parapharyngeal space and recognizing that the normal internal carotid artery is absent are the clues to a specific diagnosis. Hemangiomas, more properly called venous low-flow vascular malformations, arise in a variety of organs, and they look like tumors. They act like tumors, but they're not cellular, they're actually vascular malformations. One of the most common locations for hemangiomas is within the larynx. These happen to be the most common benign tumor to arise from the larynx. I mean, 90-some% of laryngeal masses are squamous cell carcinoma, but if it is a benign mass, then it's most likely to be a laryngeal hemangioma. It is well defined, it's briskly enhancing. Those are the clues that you're dealing with a hemangioma. The other common location to encounter a hemangioma is within the orbit. Thankfully, in the orbit, benign tumors outnumber malignant tumors, and this is in fact the most common mass to arise within the orbit. You can see a well-defined mass that is displacing and distorting the globe, and this well-defined appearance is a clue, and statistics are a clue that you're dealing with an orbital hemangioma. These often fill in slowly over time with contrast, so if you happen to get imaging at two different phases, watching it fill in, just like hemangiomas in the liver, is another good clue to the diagnosis. Let's round things out with some other tumors that can present as solid masses in the neck. Now, you're seeing lipomas here, and you're ready to hit the skip button because you know what a lipoma looks like in the neck. Well, I'll show you some unusual lipomas to keep you interested. And remember that meningiomas often traverse the skull base, and they can present, in fact, as neck masses. Here's a laryngeal fibrolipoma. I mean, this is not the same color as fat. It is clearly a fat-containing lesion because it is of lower density than water, but it has mixed fibrous and lipomatous components. This doesn't automatically make it a liposarcoma. Just because there's a couple of little areas doesn't automatically make it a liposarcoma. Now, if you want to be a little concerned that this is a low-grade liposarcoma, that's reasonable in this case, but it's a very well-defined tumor. Don't forget about the alternative of fibrolipoma. Remember that lipomas can occur intramuscularly, and here is a well-defined lipoma arising within the masseter muscle itself and enlarging the muscle. We think of lipomas as incidental findings, but some can be symptomatic, especially retropharyngeal lipomas that can cause dysphagia. So here's an example of, it's obviously a lipoma, but its location is critical. You have to recognize this as a retropharyngeal lipoma because it may be symptomatic in that location. Not everything that is of low density on CT is a lipoma. This sort of rectangular structure here looks a lot like a lipoma, or looks a lot like that fibrolipoma on the previous slide, but in fact it's a plastic piece from a toy that has been swallowed and lodged in the hypopharynx. Liposarcomas are one of these diagnoses that appears way more often on tests than in real life, but they do appear from time to time. What they tend to look like is not lipomas with a little bit of abnormal tissue in the center. They tend to look like sarcomas, aggressive soft tissue lesions that happen to have a few fatty elements. Of course, liposarcomas appear on a spectrum from extremely dedifferentiated lesions that you only know are liposarcomas when you do a genetic analysis, all the way to things that look essentially like lipomas. You can barely make out any sarcomatous elements, and they grow at a negligible pace. Most liposarcomas are in this end of the spectrum where they really look like sarcomas with just a couple of fatty elements. Remember that meningiomas can extend down from the skull base into the neck. Along the carotid sheath is a common location for these to spread. You can see that it's coming in the posterior carotid sheath, elevating the arteries and veins anteriorly, much like a vagus tumor would, because it's coming along the same path that the vagus would take. Of course, the key to this diagnosis is to identify the spread down from the skull base. Most meningiomas that traverse the skull base will induce hyperostosis, enabling you to make a specific diagnosis at the site of the primary. There are a few normal structures that patients or their physicians may perceive as a mass. These include the C1 transverse process, the carotid bifurcation, and the ptotic submandibular gland. It's really important to identify these lesions. When a patient says, I can feel something in my neck, and your report comes back, normal CT of the neck, the patient responds, are you saying I'm crazy? I can feel the mass there. Whereas if you come back and say, the mass is in the expected location of the carotid bifurcation, there's no surrounding abnormality, this is a normal carotid bifurcation that is palpable in a thin individual, the patient goes home happy, relieved that you know what they're feeling and that it is a normal, benign structure. In order to make these diagnoses, it's absolutely critical that your techs label on the skin where the patient can feel the mass with a skin marker, a metallic, or one of the fiducial markers on the skin so you know where to look to see if it actually corresponds to one of these normal structures. In thin, usually young women, the C1 transverse process may be palpable. Here's the marker that my tech placed so I know where to look, and look how close the C1 transverse process is to the skin. All you got to do is push the parotid gland out of the way, and it should be very easy to feel that as a hard mass. Look how far away it is on the other side. It's like twice the distance from the skin. That's going to be a palpable asymmetry to the patient. Here's a situation where the carotid bifurcation maybe swings a little bit closer to the skin surface. It's coming out between the sternocleidomastoid muscle and the submandibular gland. That makes it more easily palpable from the skin. You can see it's a little deeper on the contralateral side. Patients will appreciate that asymmetry. I can't quite feel it on this side. I can feel it more easily on this side. This is actually a very common thing for thin people to be able to palpate, is their own carotid bifurcation. Hopefully they don't massage it too much and get themselves to pass out. Sometimes the submandibular gland is asymmetric in size, and sometimes one is just a little bit lower than the other. If one submandibular gland is more inferior than its counterpart, we call that a ptotic submandibular gland. I usually reserve that term for when the submandibular gland comes down and reaches the hyoid bone, but it's the asymmetry that's actually important. So you can use the term ptotic anytime one is lower than the other. Why? Because that's palpable as an asymmetry. You can feel something way down low in the neck here, but you can't feel it on the other side because the submandibular gland's higher up on this side. That's a palpable asymmetry that the patient can appreciate. Here's the skin marker letting me know that that's exactly where I'm supposed to be looking. Just to review the wide variety of benign solid neck masses that we have discussed, we talked about tumors arising from nerves. We've talked about hypertrophy of various muscles in the neck. We've talked about inflammatory diseases of the carotid artery and of muscles. We talked about vascular pseudotumors from aberrant vessels. We talked about other types of masses and pseudotumors, things that aren't really abnormal at all. And we've talked about normal structures that patients or their doctors can feel as masses, but are really normal structures. This concludes the lecture on imaging of benign solid neck masses.